Good afternoon. I have the great pleasure today to be able to moderate this breast cancer tumor board for us. We're going to discuss some very interesting cases, complex clinical decision pathways, and I'm honored to be joined by my esteemed panelists. I'm going to start with Dr. O'Shaughnessy, if you would like to introduce yourself, and then we'll just jump right in. Dr. O'Shaughnessy.
Hi, I'm Joyce O'Shaughnessy. I'm a breast medical oncologist. I work at Baylor University Medical Center, Texas Oncology, and US Oncology in Dallas, Texas. Real pleasure to be here with everyone.
Hi, I'm Tom Buchholz. I'm the medical director of Scripps MD Anderson Cancer Center in San Diego, and I'm a breast cancer radiation oncologist.
Hi, I'm Rennie Butler. I'm an associate professor in the Department of Diagnostic Radiology and Biomedical Imaging at Yale. I specialize in breast imaging, and I'm delighted to be with you all.
Dave Mamones, a breast surgical oncologist. I work at Orlando Health Cancer Institute, direct the breast program there.
Our next patient is a patient with triple negative breast cancer, PD-L1 status unknown, and advanced disease. So this is a very young woman. She's 30-year-old Caucasian female with a history of stage 3C clinical T2N3M0, triple negative invasive carcinoma of the left breast, status post-dose dense doxorubicin and cyclophosphamide, followed by carboplatin and paclitaxel. She now has developed leptomeningeal involvement with no other evidence of sort of systemic distant metastasis outside of the central nervous system. And the question being posed is, should this patient be offered sort of pembrolizumab, or should the patient be considered as a part of a clinical trial for a multi-epitope folate receptor alpha peptide vaccine? So as we know, a very challenging clinical situation for these patients with leptomeningeal disease. And so we'll want to get everyone's insight. So this patient initially presented with a self-palpated nodule in the left breast and enlarged axillary nodes, performance status of 1, no significant medical history or social history or family history at all. In November of 2020, she had a bilateral diagnostic mammogram and sonogram, which demonstrated an enlarged left axillary lymph node, as well as a breast mass at the 2 o'clock position. Biopsy of the left breast and axillary nodes demonstrated invasive ductal carcinoma, grade 3, which was triple negative. In December of 2020, she underwent an MRI, which confirmed the presence of the left breast mass. There was no invasion of the pectoral fascia. There were multiple abnormal left axillary nodes that were visible. She had systemic staging with a PET CT, which demonstrated increased FTG uptake in the left breast, axilla, and subpectoral lymph nodes, as well as internal mammary lymph node. She completed dose-dense cyclophosphamide and doxorubicin for 4 cycles, and this was followed by paclitaxel every 3 weeks with carboplatin. 2 doses had to be held due to cytopenias. In May of 2021, she underwent genetic testing with variants of uncertain significance identified in CDK4 and MSH2 genes. She subsequently had an MRI of the breast, which showed no residual mass was identified, no suspicious remaining internal mammary or axillary nodes. In June of 2021, she underwent a bilateral mastectomy and sentinel lymph node biopsy, which showed uptake in 2 left axillary lymph nodes. There was found to be a minute focus of residual carcinoma in the left breast with negative margins and no malignant findings in the contralateral breast. In August of 2021, she completed radiation treatment to the left trust wall, intramammary nodes, and axillary nodes to a dose of 50 gray and 25 fractions, and a boost of 10 gray to the scar. In September of 2021, she developed a severe headache and the onset of nausea, and an MRI brain with leptomeningeal metastasis involving the cerebellar folia, trigeminal nerves, and internal auditory canal. She had CT scan of the chest, abdomen, and pelvis, which showed no evidence of other distant metastatic disease, and she was subsequently initiated on whole brain and whole spine radiation. And so, Dr. Butler, would you mind walking us through some of these images of the CNS?
Absolutely. These images of the brain MRI show the leptomeningeal metastases involving the cerebellar folia posteriorly. The yellow arrows that point toward the posterior portion of the skull point out some of these cerebellar folia areas of enhancement. In the image on the left, we can see yellow arrows in the middle of the image, also pointing to enhancement in the internal auditory canal. And in the image on the right, we see arrows in the middle pointing toward enhancement of the trigeminal nerve, which courses through the cerebellopontine angle here. In the image of the spine, just to the right of that, we also see some leptomeningeal metastatic disease involving the cervicothoracic junction superiorly, as well as the lumbar spine more inferiorly.
Thank you so much. Okay, and the clinical question being asked is, should this patient be offered sort of adjuvant, although technically isn't really adjuvant anymore, as she now has this fairly extensive CNS disease. So Dr. O'Shaughnessy, what do you feel about the role of pembrolizumab is in this situation, or would you favor a more of pursuing a clinical trial approach, or do you have other thoughts?
I think I would definitely recommend the adjuvant pembrolizumab. There are data actually showing that there was one study of 22 patients and 38% of them had lived more than 6 months, for example, with breast cancer, some other malignancies in there as well. But there's some surprisingly positive data with regard to pembrolizumab in leptomeningeal disease. My partner had a very surprising case of a very young woman. She actually chose to go home on hospice, got a dose of pembrolizumab for her leptomeningeal disease, and had a very large response, putting in a case report into the literature on that. So I would favor pembrolizumab. One could also consider, I'm impressed with how well her breast cancer responded to preoperative therapy. She has chemotherapy sensitive disease, but the leptomeninges must have been a sanctuary site. And so one could consider a DNA damaging agent intrathecally, such as thiotepa or topotecan. I would probably discuss that with her, but I looked up the multi-epitope folate receptor alpha peptide vaccine. It also has some interesting preliminary data in breast cancer and ovarian cancer, but I think I would favor the adjuvant pembrolizumab. I feel the data are a little stronger for the adjuvant pembrolizumab.
And what duration of the pembrolizumab would you favor? Would you just monitor for best response or clearing of the CSF, or how would you approach that?
I'd probably continue it as we would in metastatic disease in general, and you can certainly monitor the CSF, but I would consider it, gosh, at least 2 years, and then it would be fantastic to have the opportunity to reconsider stopping at 2 years. But in general, in metastatic disease, I go at least 2 years.
Thank you. Dr. Buchholz, do you want to comment at all about her radiation that she received, sort of whole spinal radiation, and how you approach patients in this type of situation? Do you approach them with sort of sections of the radiation given, or do you favor treating the whole spine?
Well, unfortunately, radiation isn't the complete answer. Maybe with improvements in immuno-oncology, but this case, we really use radiation for palliation. And as such, it's sometimes appropriate just to consider whole brain treatment. Sometimes we do craniospinal.
Mm-hmm. So often consider whole brain radiation or whole spinal radiation in these patients. And then, so just to summarize, I think we would definitely recommend the adjuvant pembrolizumab for a duration of up to 2 years for that patient to be followed clinically for evidence of systemic disease, and also consideration of an intrathecal DNA damaging agent such as thiotepa or topotecan to be given with the pembrolizumab intravenously as well. So I appreciate everyone's insight. That certainly is a very difficult clinical situation for this very young patient. And so thank you so much for your insights.